a base hospitals model, a bit different than many of the other provinces. And some credit goes to them taking this on. Literally every base hospital has been made aware of this, has been part of the decision-making process to allow this to go forward. And to, in particular, Dr. Phil Moran, who's our medical director at Central East Pre-Hospital Care Program, is very open-minded about these things, sees this, and of course his colleagues do as well. Now, having said that, we're still not in a time and place where we can have a full conversion, so there are things that we put in, like there are medical directives included in IMPACC because the existing regulation and infrastructure obligates that, although that's not a focus, that does exist. Secondly, we have a consultation process that looks a little bit like a patch process, but is not, conceptually, it's not the same. It really is a consultation. They're having a discussion about what might be best for this particular person, particularly when they're very complex and about to be discharged. So these are, in my view, necessary interim steps to create the change that we're talking about. And like I said, to their credit, they're open to that, but we're moving in a careful, cautious way because there is, of course, concerns for patients, risk and those kinds of things that we have to guard against as well.
I think that's such a critical piece to take away, that look at the quality assurance in place. Paramedics with extended training, and they have that conversation or consultation with the base hospital physician, say, this is what they're experiencing, that's what I'm thinking. Are you okay with this plan? What avenues can we go down? And again, that's the connector and the holistic piece to it. If you know the numbers, how long are the patches usually taking to get that very robust information out to everyone?
I don't know the exact, we have that data. I don't know it off the top of my head. It's, I wouldn't say it's, prohibitively long. And as these paramedics are having better and better relationships with the docs, and those physicians are starting to understand what they can and can't do, because it's a broader group of people that are taking these calls now because there's so many of them. And so there's a bit of a learning curve there too. It's like, wait, what, you can do what? Sometimes. But we're making those changes, and so there's, it's moving in that direction. And so it's not prohibitive. The only limitation really is that won't be a sustainable strategy. Like you can't have 700 paramedics consulting on every patient that they come into, or, these patients that are falling under IMPACC. So we're going to have to transition out of that or soften that a little bit to some extent, but it's all part of the evidence that we're collecting at the moment to determine how often, as an example, how often paramedics might be calling, anticipating to go in a particular direction, and then going in a different direction based on something that the physician is hearing, for example. Those moments of disagreement, and I mean that in a productive, positive way, but those moments of disagreement are really, really valuable for us to see, okay, well, what do we have to do with training and education? I'll give you an example. What we're starting to see, and I say this cautiously because I'm just in the process of looking at all this data. What we're starting to see is that there's I'm going to call it discomfort, but I don't know if that's the right word, with patients who are very vague complaints like weakness, general fatigue, these kinds of things, and elderly. And so everyone gets nervous, about leaving those patients, and, because there's a lot of complexity there, with elderly patients. And what that's telling us is, okay, our curriculum needs to elevate on those two things and the combination of those two things. So it's that kind of back and forth between the data that we're experiencing and the curriculum that we're building to address these kinds of innovations going forward.
It's all iterative.
Very. And like I said, it takes a lot of people and a lot of willingness to, do this, because it's uncomfortable for some people, for sure.
How long does the ACB program extend with this extra training?
It probably an extra term, semester. And the way we've done it so far is what we call a 70-30 split. In other words, we have IMPACC, sort of 30% of IMPACC sprinkled throughout the ACP program. So to use a simple example, the farm portion of the program includes all of it, not just the ALS PCS drugs. And so including common prescriptions that might be associated with these types of patients that you might need to be aware of. And then the last 70% is dedicated to a final semester where we really focus on impact related things. And that's in part because of where we are in this whole world of ACP certification and employment and, you know, all of that stuff. Two of you will know that the ACP exam for certification, for example, is a particular way. And so we have to make sure students are ready for that without messing with them too much, that they'll approach that exam in a problematic way. So, and as that exam evolves, then we will too. But for now, we have to be careful.
What a valuable return on investment, like just an extra semester of training and look what else you can do holistically. Is there known like monetary values if we implement impact, how that affects the greater healthcare system with greater savings on healthcare expenditure and improving outcomes too?
That's the holy grail right there, isn't it? In addition to patient outcomes. So we are looking at things like time on task, vehicle utilization, use of resources, that kind of stuff. Initially, it was a pretty big increase on time on task. Like they were taking a long time. They were being very, very careful. That's come down quite a bit. Again, I don't have the exact minutes in front of me, but I remember seeing that it had come down drastically. And also when you factor in the transport, offload delay times, all that stuff, we are saving, I believe, vehicle utilization hours. In other words, how often they're in contact with patient. So we're seeing that. As far as impact on the healthcare system, that's outside of my area of expertise. And so we're inviting health economics experts to help us think through that and how we might demonstrate that. We know that that's a big driver. And so we definitely have the data to do that. You know, we just haven't finalized it.
Want to be mindful of your time. I just as we look forward into the future, who needs to move most here? So if we want to see, so the system's evolving, and you've probably seen a lot of movement from all of the stakeholder groups. What has to be the biggest movement to kind of, I guess, crest the hill and start to see more systemic integration?
I'm pausing on that and thinking about that because our team at York has been so open and progressive to this that there really isn't a lot of resistance there. And the teams that we work with, like the family health teams and the Ontario health teams that we work with there, have been very, very supportive. And the Ministry of Health has been open to allowing us to pursue this kind of stuff and in fact, encouraging us. And so, you know, there's momentum and movement because all these people are in place to support it. So it's hard for me to say, like, where is the problem or where's the barrier?
Well, it kind of sounds like maybe you need a champion else, like you need consistent champion, right? Like it sounds like you've solidified that system internally. And then it's probably, probably doing stuff like this and getting the buy-in from the community where someone else somewhere else says, I want to be the champion here for something like that.
Yeah, we definitely need other partners to engage and participate. And we have had interest from other services and educators, you know, poking their head in and saying, hey, this looks interesting. You know, can we learn more? And so more and more we are, disseminating information. And this, like you said, is one of the ways to do that. There's going to be an issue at some point. And I would say that, you know, one of the challenges we have, again, is that culture transition within the front line. Some people don't think it's worth it. Of course, there are union issues related to expanding scopes of practice to attend to. There are education issues to attend to, continuing professional issues to attend to. There's a lot of things for us to attend to. But I think the biggest issues are structural. By that, I mean paramedicine systems in terms of structure sit independent of these other healthcare resources. As you know, in Ontario, paramedicine systems sit at the municipal level, healthcare sits at the provincial level. That by itself is a major structural challenge. And then you have things like what that translates into are things like data transfer. It's very, very difficult for us to move data between different organizations and sometimes levels of government. So that's one example of a massive, massive barrier to this whole thing. The care coordination and care planning, for example, is really, really difficult. Now, having said that, our partners, again, our family health teams, our Ontario health teams, open to this, know we have to get to this. We know we have to get to this. And so we're all working on it. This is probably one of the things that we are working with the most. So we need support and, buy-in and willingness to, we have the buy-in, but I think we need, solutions around things like data transfer, governance, mandates, funding, shared funding, and so on, so that we can address that very simple, but very, I shouldn't say that. It's not simple, but that very important step in integration. And there are lots of layers to integration, but that's one of them that we are struggling with. And I'll just point out, to give you another example, in Ontario, we have an event-based model of reporting. In other words, like, it's not tied to patients, it's tied to run numbers and events. And that approach doesn't exist in the healthcare system. So in other words, if a patient goes to the emergency department 4 times in a week, they see that as under the patient record, they'll see that 4 times. For us, those will be 4 independent run numbers. And it would require us to somehow be cued to that, to be able and then to pull those different EPCRs together and go, oh, okay, this is the same patient. So we have some data infrastructure issues to work through. And there's 2 colleagues of mine that are really focused on this. Yusuf Saad, who works with me in York, very, very, very focused on this. I mean, he's probably one of the leading thinkers on how to navigate this locally when it comes to IMPACC, especially. And then another one, Dr. Matt Lenar, who is in PEI, who used to be here in Ontario, is now the director of AHS there, and with the University of PEI too, has really pushed this as part of his PhD, has really said, look, we have to move off this event-based model. And so that's, if you're asking me, like, what's an important issue to resolve right now, that would be, number 1 on our list of things in terms of operations and structure.
Any last thoughts, Walter, that you could give the listeners to describe IMPACC and where it's all going?
Again, I think I just want to emphasize that we don't feel that special or anything like that. We're just trying to push this alignment concept. And if people can push their alignment concept in whatever way suits their context, that would be wonderful for patients. This is a not entirely personal venture, but, I have personal experience. We probably all do. Many of us do, where we have family members who are probably not served as well as they could be. And so that was a major push to do something about this. And then, I have to thank again so many people who have vision and trust and, and I guess respect for the process too, to allow this to go forward on sometimes very unsteady ground. And then the community I think we have here in Canada and Ontario is very collegial and respectful. And so there's a sharing that's happening and a lot of progress that's happening in lots of different ways. My only request is for people to come together in some sort of shared and unified conceptual framework so that we can, make progress together. So thank you for the opportunity to talk to you guys today and to share this work of many.
Thank you so much. And thank you for continuing to make bold and impactful changes on our profession. We really appreciate it.